Theo. And thank you for all the presenters. And you know what? We really may generate some interesting research from this conference. I think it's really exciting, but I would. Anyway, okay, so we're going to move on. And now we're going to go, and this is another study regarding COVID. And I think it's really interesting. I think it's both innovative in how it's been carried out and interesting in terms of the information it produces. We have a different speaker than the one who is on the list. And I am going to let you pronounce your own name after I absolutely slaughtered the last person's name. So how do you pronounce your name?
Himanshu Rai.
Thank you, Himanshu Rai. He's Head of Imaging and Core Lab at the Cardiovascular Research Institute in Dublin and the Mater Private Hospital. He completed his doctor thesis in 2013 in cardiovascular genetics in India, and he later received his postdoctoral research training in Germany. And he's coming to talk to us about the SETANTA study, and I really look forward to hearing what you've got to say. Thank you.
Thank you very much. Delighted to be here. So I'm pitching in for Professor Robert Byrne, who can't make it this time, but he has promised the next time he'll be here. Okay.
Can I just say thank you to Dr. Rai for coming? I think he was told he was doing this a few days ago. So
yeah.
We must give him all credit for that.
Okay. Title slide. Actually, this should come down. Yeah. Oh yeah. So thank you very much. My name is Himanshu Rai. I am the director of the Imaging Core Lab at Cardiovascular Research Institute, Dublin, at Mater Private Network, and I'm also an honorary lecturer in the School of Pharmacy and Biomolecular Sciences in RCSI University of Medicine and Health Sciences in Dublin, Ireland. This study of heart disease and immunity after COVID-19 in Ireland, acronymed SETANTA, was funded by Women as One grant, which was received by Dr. Collar. There's some issue here. Yeah, okay. Yeah, these are my conflicts of interest. Yeah, so let me tell you something about the Cardiovascular Research Institute, Dublin. It was established in 2020 by Professor Robert Byrne in partnership with the Mater Private Network and RCSI University of Medicine and Health Sciences. Our mission is to advance heart health through patient-centered clinical research, and our vision is to be the leading cardiovascular research institute in Ireland. The CVRI focuses on developing outcomes research, engaging in clinical trials, establishing an imaging core lab, that's where I come in, coordinating international meta-analysis, and we engage with collaborating clinicians, patients, industry, academia, and regulatory bodies across Ireland and also internationally. So this study, SETANTA, was funded by Women as One grant, and it was awarded to our colleague, Dr. Roisin Colleran, and it was very kindly sponsored by Mater Private Network, Dublin. With that grant, we employed Ms. Nicoletta Begosi, who was a clinical research assistant for 12 months with us. If you need to know more about CVRI, please head on to cvri.ie, that's our website, and our Twitter handle, which is at cvridublin.ie. Going on to the topic. So there were concerns about chronic cardiac injury post-COVID-19. And it all started with a study published in JAMA Cardiology in 2020 by Puntman and co-workers, a group from Germany. And they showed that 78% of COVID-recovered patients had evidence of abnormal findings on cardiac MRI at a median of 71 days post-infection. Now, they published the data and they showed that the abnormal native T1 was present in 71% of the cases, abnormal native T2 was present in 60% of the cases, and late gadolinium enhancement was also present in 32% in the myocardial territory, 20% in the non-ischemic territory, and 22% in the pericardial territory. This was also paired with significant p-values and differences in terms of native T1 values when it was compared with healthy controls and risk factor matched controls. So you can see T1, T2, native T1 and T2, and LGE had significant p-values. Now, one thing was noted that the Puntman et al., the study group, had 1/4 of their cases admitted in hospital during the index infection. Now, there was another evidence that came a year later from Joy and co-workers, and the paper was published in JACC Cardiovascular Imaging in 2021, where seropositive COVID patients, when compared to controls, which were seronegative and never had COVID, the T1 and T2 values were very similar, numerically high, but very similar, and there was no p-value, no significant p-values there. So there was a controversy there, what is correct and what is not, and which led to our study, that was SETANTA. The study design is as follows. The aim was to investigate the prevalence of cardiac abnormalities by cardiac MRI in unselected patients in Ireland after acute COVID infection and its correlation with immunological response and biomarkers of coagulation. It was a prospective, community-based, single-arm observational study, and cross-sectional population was included. Key exclusion criteria was any adult who had SARS-CoV-2 infection more than or equal to 6 weeks and less than or equal to 12 months before enrollment were included, and the evidence they had to produce was a positive RT-PCR nasopharyngeal swab. Obviously, written informed consent was required. Any history of myocarditis or ischemic heart disease was an exclusion criteria. Contraindication to gadolinium or regadenoson was also amongst the exclusion criteria. And obviously, insufficient cardiac MRI was also one of the exclusion criteria. Now, we reached out to the GPs so that they could advertise the SETANTA study, and interested participants contacted us rather than us contacting them. In total, 129 contacted us, amongst which 100 were found to be eligible, and they did a site visit with baseline blood investigations and also cardiac MRI. Additionally, SAQ-7, Seattle Angina Questionnaire 7, and EQ-5D-5L, which is a quality of life questionnaire, was administered at baseline. Additionally, ECG and 24-hour ambulatory ECG monitoring was also done. In the end, 96 patients underwent cardiac MRI. Clinical follow-up was at 1 month, 6 month, and 12 month post enrollment. At 6 month and 12 months, SAQ-7 and EQ-5D-5L was also administered again. The primary outcome of interest was evidence of cardiac injury as detected by cardiac MRI, and secondary outcomes were anti-SARS-CoV-2 antibody levels and markers of coagulopathy. These are the results. So from 100 patients, only 4 were hospitalized during their index illness. 3% were admitted to ICU for ventilatory support. 18% at the time of index infection had severe symptoms, whereas 35% had moderate symptoms at the time of index infection. Clinical characteristics are given at the table here. Median age was 45.2. Mean age was 45.2. 64% were females, overwhelmingly Caucasian. There was nothing to report in terms of baseline parameters, other than 12% had hypertension, 20% had hypercholesterolemia, 41% had any history of smoking, with 9% with current smoking. When we looked at cardiorespiratory symptoms since their initial diagnosis, 41% of patients had at least one episode of chest pain since their diagnosis, 54% palpitations, 53% dizziness, and 62% dyspnea. 23% of the patients were classified with New York Heart Association Class 4. Now, SARS-CoV specific symptoms, surprisingly, 17% had a loss of sense of smell as a persistent symptom at the time of inclusion. 15% had loss of sense of taste. 43% had fatigue or malaise. 22% had headache, and about 6% had GI disturbance. In total, 83% of the patients had any ongoing symptoms at the time of inclusion. The results from biochemistry and serology are here. The surprising thing is D-dimers, fibrinogen, von Willebrand factor, which are all markers for coagulopathy, are increased in 11%, 10%, and 33% respectively. Additionally, ferritin, lactate dehydrogenase, soluble ST2, and galactin-3 were also increased in fair number of patients, from 20% to 40%. We also did the SARS-CoV-2 specific antigen test, which was specific to the acute to the illness at index infection, and 86% were positive at the time of inclusion, which was at 189 days post-infection. General antigen was also positive in 96% of cases. The CMR results are here. You can see that there is numerical difference in terms of native T1, T2 values, but the significance is not there, partially because we did not test for significance. We did not have healthy controls to compare with, but the reference ranges were ascertained from age, sex, and scanner-specific controls. The stress perfusion imaging was not abnormal for any of the patients. Late gadolinium enhancement was only abnormal for 2.2%. Pericardial effusion was only seen in 8 patients out of 96, where a moderate sized pericardial effusion, that is 12 millimeters, was only seen in 1 patient. In the right, you can see the stills from the CMR, which shows basal infralateral high signal on LGE, and in the bottom you see a small pericardial effusion within 6 millimeters and 12 millimeters that is classified as a moderate sized pericardial effusion. We also administered a Seattle Angina questionnaire that was modified for our purposes. We excluded the last question, which is the 7th question, which refers to the nitroglycerine use, because these were not cardiac patients. You can see a steady rise in terms of activity, questions regarding to activity, questions regarding to chest pain, breathlessness, cardiac symptoms, and their happiness or their content with the symptoms from baseline to 6 months to 12 months. The second questionnaire that we used was a quality of life questionnaire, which is SEQ7, where, EQ5L5D, and here also in the dark green you can see a steady improvement from baseline to 6 months to 12 months in almost all questions regarding mobility, self-care, usual activities, pain or discomfort, or anxiety or depression. And the health scores are steadily rising from baseline to 12 months. So what did you find? What was the conclusion from this study? In an unselected cohort which underwent CMR at a median of 189 days after acute COVID-19 infection, there was very mild numerical increase in native T1, post-contrast T1, and native T2 values compared to the age, sex, scanner-matched reference controls. And nonetheless, late gadolinium enhancement was infrequently observed in just 2% of the cases. Markers of coagulation and inflammation remained elevated at in a significant proportion of patients, indicating ongoing increased risk of cardiovascular events. There was a very high prevalence of persistent symptoms at 189 days post-infection, which was at 83%. And whether this CMR findings are clinically relevant, that requires more study. In the end, thank you to all the colleagues who participated, and thank you all for listening. Thanks.
Thank you very much, and thank you for putting together quite a complex study in a very short space of time and communicating it to us. One of the things I really like about this study is the way it combines going out to the general public in the community setting and combining it with the complexities of a scientific and hospital setting. I think it's really good when we can combine those two groups and collaborate together. Is there anybody who has some questions from the floor? I have a question myself. One of the things I was wondering is, with the inflammatory markers, you saw an increase in inflammatory markers, and 40% of this, 33% of that, 11% of that. Was that generally in the same patient? So what I'm asking is, was it that 40% of patients or 30% of patients, they all had the same inflammation, or was it across a range of patients?
It was across a range of patients. We tried to see how many patients had multiple markers elevated, but we did not find a statistical sense out of it. So it was distributed across all patients, essentially. Yeah.
And then just in terms of, you talked about controls in the last slide, but for example, you had 83% of patients experience symptoms 189 days after their COVID experience. Was that, it was a self-selecting group, do you think that was, or was there a control group that you could compare?
So this is actually one of the limitations of the study, that the patients themselves put forward to be scanned. Now, there can be a selection bias because the sicker the patient is, the more ready the patient is to get scanned. We did not purposely take a control group because A, it is harder to find, B, it is harder to convince them to have a cardiac MRI, which is anyways takes time and efforts. And we just wanted to see from a cross-section of patients which are sicker, which come forward, if there are any cardiac abnormalities in that cohort, and we didn't find one. So sure, the next step would be to have controls, but then now the disease has become quite benign, and we probably won't find controls which never had COVID, actually.
And so thank you for that. That allows us insight. And just out of interest, I mean, my perspective from reading about the study is that this is quite reassuring in terms of the long-term consequences on the heart. Is that?
Yes. So that was the overall sense, that this study is quite reassuring. Although what happens with the heightened inflammatory markers in the long course of follow-up, nobody knows. We need longitudinal follow-up for years and years from this cohort just to see if there is a difference between incidence of any cardiac abnormalities down the line. So we really don't know at the moment.
That's really interesting. You did flag that, saying high inflammatory markers are linked with cardiac events and clotting and things, so that was flagged. Thank you very much. That's very interesting.
Thank you. Thank you very much. Thanks.